This is the second video of the burn series, and in the first video, we talked about what is a burn, pathophysiology, clinical features, and how to assess the severity. And if you guys haven't checked it, I'll attach a link right here. Today's topic is management of burns. The initial assessment and management of severely burned patient is similar to the approach of a major trauma patient. So timely application of simple emergency measures can help to minimize the morbidity and mortality of burn injuries. First step is to make sure that you are safe to approach this patient, particularly in house fires, electrical and chemical injuries. Once you approach the patient, immediately stop the burning process and remove any burning or hot items from the skin contact. Stop, drop and roll is a good method of extinguishing fire burning on a person. Then proceed to check for other injuries. Quickly go through primary and secondary survey, and both should be repeated frequently to identify any deterioration in the patient's status that indicates the need for additional intervention. The healthcare providers should obtain an initial ample history, that is, allergies, medications, past medical history, last oral intake, and events of injury. The primary survey assesses the ABCDE, that is, airway, breathing, circulation, disability, and exposure. In the burn patient, attention should focus on the airway, looking for any burns around the nose, mouth, because that might cause swelling, obstruction, leading to breathing difficulties. And if they have bleeding or circulatory problems, we can assess it by checking the blood pressure, heart rate, and pulses. After that, we go through the secondary survey. So what do we do in the secondary survey? We do a complete physical examination to evaluate the severity of the burns so that we can optimize the management plan. We also do documentation, baseline blood levels, and x-rays. One key detail that you really have to pay attention is to who to intubate before the arrival of the hospital. Comatose patients, symptomatic inhalation injury, deep facial burns, and burns over 40% of total body surface area. Burn severity is determined by the patient's age, the percentage of total body surface area, depth of burn, type of the burn, and the location of the burn. We have covered all of these in our previous videos, so please go have a look if you are not familiar with it. Patients are classified as having severe burns if they have any of the following: more than 10% involvement in the total body surface area in children less than 10 years old or elderly more than 50 years old, more than 20% involvement of total body surface area in adults, more than 5% involvement full thickness burns, high voltage electrical burns, and significant burns to the face, eyes, ears, joints, or genitalia. Other factors that should be considered and will increase this patient's morbidity and mortality are associated inhalation injury, associated traumatic injury, and the patient's baseline medical conditions like heart disease or lung disease. Severe burn wound management should be directed to a burns unit, and the criteria for the admission to a burns unit is as follows: suspected airway or inhalation injury, any burn likely to require fluid resuscitation or surgery, patients with burns of any significance to the hands, face, feet, or perineum, patients whose psychiatric or social background makes it inadvisable to send them home, any burn in a patient at the extremes of age, any burn with associated potential serious sequelae, and high-tension electrical burns. Before transferring these patients, it's essential that a gastric tube is inserted in patients who have symptoms like nausea, vomiting, or abdominal distension, and also if their burns involve more than 20% of total body surface area. This is to avoid vomiting and possible aspiration. Management of burns requires a multidisciplinary approach which includes an intensivist, burn specialist, pain specialist, infectious disease expert, emergency department physicians, wound care nurses, dietitians, and physical therapists. Next up in the management is fluid resuscitation. So why do we resuscitate? The principle of fluid resuscitation is to maintain the intravascular volume following a burn, so that your body has the sufficient circulation to perfuse not only the essential visceral organs like brain, kidney and gut, but also the peripheral tissues, especially the damaged skin. Who needs fluid resuscitation? In children with burns over 10% total body surface area, adults with burns over 15% total body surface area, and these fluids are administered through a large caliber intravenous lines. If the patient is having more than 30% involvement, central venous lines should be used. How do we calculate the fluids? For this, we use the Parkland's formula. That is, volume of fluid equals total body surface area of the burn multiplied by weight of the patient times 4. And half of that amount is administered within the first 8 hours starting from the time of injury onset, and the next half in the subsequent 16 hours. The rate of infusion will vary according to the patient's response and urine output. The types of fluids that you can use. Ringer's lactate is the most commonly used crystalloid. Hypertonic saline is also effective in treating burns because it produces hyperosmolarity and hypernatremia. This reduces the shift of intracellular water to the extracellular space. When talking about colloids, human albumin solution is a commonly used colloid because plasma proteins are responsible for the inward oncotic pressure that can counteract the outward capillary hydrostatic pressure. So basically, the proteins will prevent water from leaking out. Protein should be given after the first 12 hours of burn because before this time, there's a massive fluid shift causing the proteins to leak out of the cells. How do we monitor this patient? The key to monitoring of resuscitation is urine output. So insert a urine catheter. Urine output is a sensitive indicator of the patient's volume status and reflects renal perfusion. Urine output should be between 0.5 to 1 milliliter per kilogram body weight per hour. If the urine output is below this, meaning that is less than 0.5 milliliters per kilogram body weight per hour, the infusion rate should be increased. If the urine output is inadequate and the patient is showing signs of hypoperfusion, that is restlessness with tachycardia, cool peripheries and a high hematocrit, then a bolus should be administered. Actually, the fluid rate that a patient requires depends on the severity of the injury. If the target urine output is not reached with the initial resuscitation rate, the fluid rate should be increased until the urine output is appropriate. Analgesia. Adequate analgesia is a must, specifically to reduce the early metabolic stress and to prevent post-traumatic stress disorder. Pain control is best managed by IV medication. Energy balance and nutrition. Burn injuries are catabolic in the acute episode. Any adult with a burn greater than 15% or 10% in children has increased nutritional requirement. All patients with burns of 20% of total body surface area or greater should receive a nasogastric tube. Feeding should be started within 6 hours of the injury to reduce the gut mucosal damage. Albumin infusion is given to maintain the serum albumin at 2 grams per deciliter. IV potassium supplementation is also done to maintain serum potassium levels more than 3 milliequivalents per deciliter. Infection control. Burn patients are immunocompromised, so they are susceptible to infection from many routes. They have compromised local defenses in the lungs and the gut because of the edema, and they also have monitoring lines and catheters, which themselves represent as portals for infections. So sterile precautions must be rigorous when treating these patients. Surgical approaches. More complex burns may require excision and skin grafting. And finally, hysterotomy is offered for circumferential full-thickness burns in the limbs. This can create a compartment syndrome effect and resulting in ischemia. So by doing an hysterotomy, they will surgically divide this burnt tissue to subcutaneous tissue to relieve the pressure buildup. Tetanus prophylaxis. Burns are considered tetanus-prone wounds. So tetanus toxoid should be given if not given in the past 5 years. Rehabilitation. Physiotherapy needs to be started on day 1 forward because all burns cause swelling, especially burns in the hands. So elevation, splintage and exercise reduce swelling and improve the final outcome. Finally, psychological support. A major burn is an overwhelming event to the person. So it can be very challenging. So psychological support should be given to these patients. Thank you for watching until the very end of the video, and if I've helped you in any sort of way, and if you guys like this video, please hit the like button and comment down below, and on your way out, please hit the subscribe button. I hope to see you guys in the next video, and this is the MedSurge.